Good morning, everyone. Good morning. Welcome to Brookings. I'm Mark McClellan from the Engelberg Center for Healthcare Reform here at Brookings. I'd like to welcome you all this morning to today's event. We appreciate your coming out early for this event on the new health insurance marketplaces, a status report. I'd like to also thank all of you who are joining us online for this event. We are now 98 days away from October 1st, the day that open enrollment begins, and Americans who don't have coverage now will have the opportunity to sign up online, shop and compare among insurance plans, determine their eligibility for a subsidy to buy insurance, and actually enroll in coverage. Then the insurance marketplaces will begin providing coverage. The insurance plans through the marketplaces will begin providing coverage on January 1st, 2014. Secretary Sebelius said yesterday that she's hopeful of around 7 million Americans getting coverage through the exchanges beginning in 2014, and millions more are expected to enroll in the years after that. The exchanges or marketplaces will also affect coverage for millions of Americans who are in the individual market today, and millions more who work for small businesses that will be participating in the small business insurance marketplaces under the new coverage. So this is the cornerstone of the Affordable Coverage Act for 2014, and that's what we want to talk about today. How are things going? What's likely to happen from here? I'm very pleased to be joined by my friend Governor Mike Leavitt and by two key leaders from the Center for Medicare and Medicaid Services, Gary Cohen, the Deputy Administrator and Director of the Center for Consumer Information and Insurance Oversight at CMS, and also Mandy Cohen, no relation, the Senior Advisor to the Office of the Administrator at CMS. Mandy's deeply involved in the education and outreach activities related to the ACA and the marketplaces. This morning, we're going to first hear from them about an update on the current status of the health insurance marketplace implementation, and also about the outreach and education plans that are underway and that are planned for the months ahead. Then Governor Leavitt and I are going to participate in a roundtable discussion with Gary and Mandy about insurance marketplace implementation. And that discussion is going to draw on our experiences, Governor Leavitt and my experiences with Medicare Part D, and how some of the lessons and experiences from that last major program implementation may be relevant today. After that, we'll have time for questions from all of you, and we're looking forward to hearing from you. And as you can see from the timeline that, well, you probably can't see it from your seats, but as you can see from the timeline that will be available online in conjunction with this event, there are a lot of activities underway, and a lot of work has already been done towards implementation of the marketplaces. This includes finalizing the rules and regulations. Many of those were completed earlier this year. It includes the submission of bids or proposals for coverage from the qualified health plans. That happened at the end of April, early May. Right now, those plan submissions are under review by CMS and by states that are running some of the exchanges, with expectations that the decisions on those plans and their coverage features that will be available will be finalized by late this summer and announced by September. Then coming October 1st, as I mentioned, the open enrollment period for the marketplace plans begins. Late this year, in November of this year, states are expected to submit their decision about their intent for operating their insurance marketplace for the year 2015. And then on January 1st, 2014, insurance coverage begins, and in March of 2014, the initial open enrollment period for coverage for the marketplaces ends, and after that point, people who don't have coverage are expected to pay the penalty. So a lot ahead in the coming months. This map, which may be a little bit clearer from your seats, shows where the different states are as of today in terms of their plans for implementing insurance marketplaces or working with the federal government to do so. 16 states in the District of Columbia are running state-based marketplaces where the state is responsible for all core exchange functions. Idaho and New Mexico, the ones that have the asterisks on the slides, will be partially supported by the federal government, but primarily running their exchanges. 7 states will establish state partnership marketplaces: Arkansas, Delaware, Illinois, Iowa, Michigan, New Hampshire, and West Virginia. These states can conduct plan management activities as well as consumer assistance, outreach, and education functions. In addition, 7 states, Kansas, Maine, Montana, Nebraska, Ohio, South Dakota, and Virginia, chose to pursue the marketplace plan management option, and under this option, a state has to conduct the same plan management activities as in a state partnership marketplace, including submitting recommendations for plan certification to CMS, tracking and resolving consumer complaints, and ensuring continued compliance with the certification standards, but otherwise the exchange is federally run. Utah has a bifurcated model where the federal government is running the individual marketplace, and it will continue to run its state-based small business marketplace. And that leaves 19 states that have opted for no formal role in exchange operations. These states have the sort of fully federally run insurance marketplaces. So that's a little bit of an overview of the status of the states right now and framing for the discussion that we're about to have. Right now, I'm very pleased to introduce Governor Leavitt. He's the founder and chairman of Leavitt Partners, previously served as governor of Utah for 3 terms, as well as administrator of the EPA, and then a time when we spent a lot of days and nights together as secretary of the Department of Health and Human Services from 2005 to 2009. Mike?
Thank you, Mark. Some months before January 1st of 2006, I was speaking with a friend of mine and trying to describe the complication of implementing Part D. I described the 50 different Medicaid systems that needed to exchange data in a separate way, the thousands of different insurance plans that had to do something similar, the fact that there would be literally tens of millions of people making individual decisions, preparing for that had material impact on their lives. And I said something to the effect, I hope next time Congress decides to implement something as rigorous as this all on one day that they'll talk to me. They didn't, and here we go again. May I say that Part D, in retrospect, turned out to be what I think will be a notable historic success. However, there were moments during that implementation that it felt very fragile. I will not soon forget January the 1st, 2006, when we flipped the switch and sat back to see exactly what would occur. Larry Colcutt, shortly after midnight, I think, went out to a series of pharmacies and reported to me at one point that he had asked the pharmacist if he had received any Part D prescriptions yet. And as I recall, his answer was, yes, 1. But that was the beginning. Over the course of the next several days, we experienced what would have to be considered a wild ride. Problem after problem after problem, despite our great efforts to prepare, began to manifest themselves. And problems, when they manifest themselves, when millions of people are trying to do the same thing simultaneously, that can be complicated. Now, the good news is, in the final analysis, this turned out well. But today, as we begin to move toward implementation of the Affordable Care Act, I'm delighted to be sharing some of our experiences. But once again, I think it needs to be acknowledged that there are significant policy challenges here. There are almost unimaginable complexities in the context of the technology that has to come together for computers to talk with each other. There's the logistics of getting people to talk together. Sometimes getting computers to speak with each other is the easy part of a task like this. getting the people to work together, the sociology is more difficult than the technology, and not to mention the politics. Now, it's very clear that this plays out, as did Part D, with the backdrop of politics. But it's important for all of us to remember that it's not political parties who are affected in the long run. It's people. And in many cases, it will be millions of people, many of whom are the less fortunate and those who have dramatic health problems and those who have expectations. So I think that today's discussion will be important, that we get a good fix on exactly where we are. Anticipation is a very important part of doing this well, and this kind of conversation, I'm confident, will allow not just those who have expectations of its benefit, but the literally tens of thousands of organizations who are working to fulfill their role. That can be insurance plans, it can be providers, it can be pharmacies, it can be those who serve those in need. This is a very rigorous national project, and so Mark, thank you, Brookings, for the sponsorship of this, and I look forward to the conversation.
All right, thanks very much, Mike, and let's get right to it. I'd like to ask Gary Cohen to come up and provide an overview of the status of marketplace implementation.
Thank you, Mark. It's great to be here this morning with all of you and with all of you who are watching over the internet. You know, I told my wife last night that I was going to be speaking at the Brookings Institution, and she said, "At the Brookings Institution?" And she's seen me testify before Congress, and that was not so impressive. But the fact that I was coming here today impressed her so much, she said, "You need to take a picture out in front of the building, you know, where it says the Brookings Institution." So we did that. So I'm very pleased to be here, and it's a great honor. I'm going to cover kind of an overview of where we are with marketplace implementation and a few other things affecting the broader insurance market. Our goal, what we're trying to accomplish, the landscape of where we are today with the marketplaces, some key accomplishments, some key dates that are coming up over the course of the rest of the year. I'm going to talk a little bit about what we're seeing with premium rates and a little bit about what we just published with respect to the results that we saw for last year on medical loss ratio. Our goal, obviously, is pretty straightforward: to ensure that Americans have access to quality, affordable health insurance. I would just pause there for 1 second to remind everyone that there's a lot more to what the Affordable Care Act does with respect to that goal than just the marketplaces. There is a transformation happening in the broader insurance market. Obviously, guaranteed issue, which goes into effect in 2014, is the biggest thing. Which means that people who historically have not been able to get coverage, or either because it just wasn't available to them or because it was too expensive, will have access to coverage without regard to health condition. They'll also have the security of knowing that there are no annual and lifetime limits in case something terrible happens and they really need prolonged expensive health care over the course of a lifetime. And there will be limits to maximum out-of-pocket costs, too, to make sure that the burden of health care costs are contained. So while the marketplaces are obviously a very important part of what we're doing, they are just a part. And as Mark said, a lot is going on, a lot has been accomplished, and will continue to be happening throughout the rest of the year. I think, as you're seeing with the increased activity across the federal government, that we are all in on this thing, and we're bringing together resources from across the federal government to both in connection with implementation and in connection with outreach and education to make sure that people know what this law can do for them and how to access it. And Mandy will be talking more about that in a little bit. I think Mark has pretty much covered in a much more attractive fashion the landscape of where we are with the states. I would just say that one of the key themes of the way that we have implemented the Affordable Care Act throughout has been to be respectful of the state's traditional role in regulating insurance. And that remains true regardless of what type of exchange will be operating in the state. The states continue to have a significant and important role in regulating their own insurance market. And that's a goal that we, share in the administration, that we welcome our relationship with the states, regardless of whether they're operating their own exchange or whether the federal government, at least for 2014, will be operating the exchange. The states have a very important role in moving that forward. In terms of key accomplishments and policy, the majority of our rules are now final and complete. There's still a little bit of work to be done, and so there's a couple of rules that need to be finalized and some more guidance that will be coming out. But by and large, stakeholders know, kind of what the rules of the road are going to be for 2014. And we have and will continue to provide a great deal of technical assistance to stakeholders, specifically, most importantly, states and issuers. And I would say that we have been extremely gratified and impressed by the working relationship that we have with our partners in this. For the most part, regardless of whether states were among those who embraced the Affordable Care Act or among those that did not embrace the Affordable Care Act, we work very closely with state insurance departments. Everyone recognizes now that this is the law of the land and this is happening, and they want to make sure that their citizens get the benefit of the law. In connection with the insurance companies, I think a terrific example is the process that we went through when we took the submissions for qualified health plans to be sold through the exchange. We did webinars, we did conference calls, we answered literally hundreds of questions that came in through our help desk throughout that process. We did a lot of one-on-one, sort of hand-holding to make sure that every insurance company that wanted to offer plans in the federally facilitated marketplace was able to do that. And we were successful in getting, more than 120 issuers in. And as Mark mentioned, those plans are now being reviewed, and issuers will have an opportunity to cure any problems that that appear through our review, and then have a chance to take a look at what will be displayed in our on our website when open enrollment begins in October. So we very much value, obviously you can't have a market without products to sell, and we very much value the relationship that we've had with the issuers as we've been going through this process. At the same time, applications are coming into the state-based marketplaces. They have their own deadlines and are working on their own schedules and calendars. And whether it's the state or the federal government that is operating the marketplace for 2014, those plans are being reviewed to make sure that plans meet the benchmark for essential health benefits and actuarial value, satisfy network adequacy requirements, and do not have any discriminatory benefit design. As Mark mentioned, later in the summer, we will be announcing and making public the plans that will be available on the in the federal marketplaces. In terms of IT, as I mentioned, the QHB submission is complete. The Federal Data Hub, that's the place where when people are filling out their application, they're going to enter certain information, most importantly about their income, to determine what they're eligible for in terms of whether they qualify for Medicaid or CHIP on the one hand, or for tax credits and cost sharing reduction on the other. That data will be pinged against database that's maintained by the Data Hub. That will be information from the IRS, for example, of prior year's tax returns, so that we can check to see whether the information that the person has entered matches up with what they have filed in the past, so that we can alert people if something is off. Obviously, it's very important that people be accurate in what they say their income is, because if they get a tax credit and then it turns out they weren't entitled to it, there are going to be consequences for them at the end of the year. So we have begun testing of the Data Hub. It's well along in terms of the internal sources of data that we are using, the IRS, Social Security, Homeland Security, and then we've also begun testing now with issuers so that they can, and states, so that they can make sure that the part of the process that they're involved in is also underway. We recently began also testing the enrollment and reconciliation process with issuers. That's the process that when someone goes to the Plan Compare portion of our website and chooses a plan, that information that they have entered into in creating their account on healthcare.gov, then has to go out to the issuers so that they can actually get enrolled in coverage, pay their premium, and be covered starting in January 1st. We've begun to test that portion of the IT system as well. In terms of the state-based marketplaces, one of the things that's truly inspiring to me is when I have an opportunity to talk to the folks who are out there in the states and building this thing for themselves, and the excitement that there is around that in terms of being able to create something that they feel they really own and that really is best for the people in their state. And we are very pleased with the progress that we're seeing across the country with the state-based marketplaces. As I mentioned, they've begun testing connectivity with the Data Hub. Most of the QHP submission windows for the states have closed at this point, and they're reviewing the plans that have been submitted. A few of them are still to come. Some of the state-based marketplaces have made the bids, the premium rates that have at least been submitted for review, public, and I'll be talking about those in a minute. As with the states also have an opportunity to come up with their own application if they choose to. They can make certain changes to the application to tailor it to what they want to do, and so those applications are being worked on right now as well. Some key dates, as I mentioned, most of the policy guidance is now complete. We have a few more things that are coming down, but on the whole, it's pretty much done. Next month, we'll begin training for all the various people who are going to be out helping people to understand what the law offers them and helping them to get enrolled in coverage. In September, we'll be providing information on our website for where people can go. The Navigator grants will be awarded in August, and so by September we'll have information about where people can go to get help in getting more information and getting help enrolling in coverage, and obviously October open enrollment begins. So just to sum up, we read a lot of stories asking the question, are you going to be ready? What's going to happen? Is this going to work? And I understand that. This is a big thing, and it's important, and there's a lot of curiosity about how it's going to go. And I think Governor Leavitt's comments are really, on point to this. Yes, this is happening. People will get enrolled in coverage. They will have health coverage in January. Will it be as wonderful on the first day as it is on the 30th day or the 60th day or the 90th day or year 5? Maybe not. I certainly wouldn't claim that we're not going to have any problems at all and everything's going to work perfectly. I'd like for that to happen, but it would be a surprise, I think, if that were to happen. So we have to recognize this is a big thing. It is complex. It does involve a lot of people and a lot of moving parts in terms of technology and other things, but it is happening, and we're on schedule. We're hitting our milestones. I think the QHP submission was a major milestone that we said we were going to do it April 1. We did. It was successful. It took a lot of work. It took some long nights, but it got done. And I think that's what we're going to continue to do. And I think that Governor Leavitt's other point is important to keep in mind, which is when you ask people today out there in the actual world about Medicare Part D, I would guess that there aren't many who the first thing that comes to their mind are the problems that occurred when it first started. What they think about is the benefit that they are getting today. And the same thing is going to happen with healthcare reform. And so, things take a little bit of time and a little bit of patience, but we will get there. In terms of rates, obviously there's been a lot, again, of sort of speculation and forecasting of what rates might look like. And I think we're getting some evidence now from states that have released rate data. A number of states have state laws that when rates get filed, they are made public. It's important to keep in mind that for the most part, those rates are proposed rates and are subject to review by the state. In some cases, the state has prior approval authority, can actually tell an issuer, no, you can't charge that rate. In other places, they don't have that authority, but they can still use, sort of their influence and negotiation to moderate rate increases that they think, or rates that they think may be too high. I think overall, what we're seeing is not surprising. There are parts of the country where the health insurance marketplace today is extremely concentrated, where there is one dominant carrier that controls 50, 60, sometimes 70% or more of the market for individual and small group. In places like that where there is not a lot of competition, it's not surprising that you would see that has an effect on what sort of rates get charged, whereas where there's more competition, that has the effect of keeping rates lower. And one of the things that we're very gratified that we're seeing in the submissions that came in to us for the federally facilitated marketplace is a number of new entries, new entrants, companies that were not previously in the individual market, for example, that are coming into the individual market because they see this opportunity of, obviously there are all these folks out there who are not insured, so they don't have any allegiance to any particular carrier today, and this is a great opportunity for them to come in to a market and establish a presence there. So you may have seen recently a study that Avalier put out. They looked at 9 different states, and what they saw was that rates seemed to be coming in lower than what the CBO had predicted they would be. For example, CBO had estimated that the nationwide average of the second lowest cost silver plan, which is used to determine what the tax credit would be $433 a month, and all of the rates that had come in the states that Avalier looked at were lower than that, and in some cases substantially lower. California, which has adopted what's called the active purchaser model, so they are not they're going to choose which plans they will be able to offer on the exchange. They recently published some results which we think are very significant. For example, in the northern part of Los Angeles, a 40-year-old with an annual income of $23,000 after getting a subsidy of $195 would pay $27 a month for a silver plan. The silver plan is a pretty generous plan. A 40-year-old with an annual income of $28,700 would pay $162 after getting a subsidy of $60. We're seeing rates that we think are very affordable and reasonable. In the federal facilitated marketplace, we won't be publishing rates until September, so that information will be coming out. But based on what we're seeing in the states, we're seeing that many consumers will actually see lower rates in 2014 than in 2013. For example, in Oregon, the average premium in 2011 was $223 in the individual market, and there are 3 issuers that have proposed rates for bronze plans that are less than that amount. Again, the effect of competition, we saw some issuers, because the rates were public in Oregon, we saw some issuers come in after the rates were published and say that they wanted to lower their rates because the rates that they had initially filed they thought were too high. Turning to medical loss ratio, as you know, the medical loss ratio rule, or the 80-20 rule, requires that insurance companies spend at least 80 cents, and in the large group market, 85 cents of every premium dollar on actual health claims or on activities that improve health quality. If they don't spend at least that much, they have to rebate back to a portion of the premium back to their customers so that they effectively reach those levels. We put out a report last week showing that because of increased MLRs in 2012 over 2011, in addition to about $500 million in rebates that are going back to consumers, consumers had actually saved about $3.4 billion in premiums over what they would have been if the MLRs had not been going up. What we think this shows is that insurers are continuing to adapt to the law. More of them are reaching the threshold that's required or that's set forth in the law. The amount of money that was spent on claims went up faster than premiums did. The existence of the medical loss ratio requirement motivates issuers to make sure that they don't charge premiums that are too high and that they operate more efficiently and in a more cost-effective manner, and the results are that consumers are getting better value. And there are a number of charts that we published in the report to show that compared to 2011, while the amount of rebates was lower, this actually isn't not a bad thing. It's a good thing. It's an indication that more issuers are meeting the standard, and insurers and that consumers are getting better value for their health care coverage. And that's, this graph shows that more enrollees are receiving this upfront value in terms of what they're getting for their premium dollar, as opposed to getting a rebate at the end of the year, and that overhead spending had declined. Administrative costs as a percentage of premium had declined in 2012 as compared to 2011. So that's pretty much it for the quick survey of what is happening in terms of marketplace implementation, and I look forward to answering your questions later on.
Gary, thanks for covering a lot of ground in that overview, and now I'd like to turn to Dr. Mandy Cohen.
Good morning. Thanks, everyone. So you can tell I'm taking a slight detour from my clinical background to talk about outreach and enrollment, but my last name is Cohen, so it seems to fit that I should work on the marketplaces. So happy to join you this morning. I'm going to walk through a couple of things. First, about who we're outreaching to. Second, how we're thinking about doing that outreach and our strategy for how we're going to use the time remaining. And then the campaign that we kicked off as of yesterday with 100 days left. So this is good timing, so you can hear about what we're up to over the course of the summer, and then, of course, the 6 months of open enrollment. So just a bit about who is it that we are trying to reach out to. So we know that there are about 41 million eligible uninsured, and that's if every state expanded Medicaid. That's the folks that would be eligible. But we need to get so much deeper than just that number. This is a very heterogeneous group, and if you're going to reach them, you have to understand who they are, where they are, what they care about, and how they like to receive information and who they trust. And so we've been doing a lot of that work at HHS. So we know some information from the census itself. Some of the things you'll see on the right-hand side of the screen in terms of where folks fall in the income spectrum. You can see 92% of folks actually fall under 400% of poverty, meaning that they're going to either be eligible for Medicaid expansion in those states that choose to expand, or for financial assistance through the private health insurance marketplace side. So, a lot of folks here who are currently uninsured do stand to benefit. We know that 20% of those have not graduated high school. We know most of these folks actually are working full-time, multiple jobs, but don't have health insurance. We also know that folks don't just rely on English, they rely on Spanish and other languages as well. And so we've been taking that all into our work. The thing I wanted to talk about in terms of who we're reaching out to is that we know we had to look at our resources, limited as they are, and start to think through who do we really need to prioritize in terms of reaching out to. And it quickly became apparent from our research that the demographic that is challenging to reach, and thus we needed to prioritize, is those that are 18 to 35. They don't wake up every day thinking, hey, I really wish I had health insurance. They're thinking, I'm young, I'm healthy. Actually, 96% of those in 18 to 35-year-old have no chronic illnesses, but they think they're invincible. Often have never had insurance, as a child, but now as a young adult do not have insurance. And so we also know that they're the most heavily marketed to. So really hard to break through to this group. So because of those reasons, we know we had to put an extra emphasis on the 18 to 35-year-old cohort. And so we've tried to learn as much as we can about them. And you can imagine for CMS, this is somewhat of a new audience. We talk a lot to people who are over 65. We know exactly who those are. If they're over 65, we have their name and their address, and in fact, we send them a handbook every year. So this is a different audience for us. So we've been learning a lot about them. We know that they skew slightly male. We know that 26% are Latino, 18% African American. We've been thinking about who are their trusted messengers and where they get their information. So I'll go through that in a second. And then as others mentioned, we sort of know the universe of the expectation of us for this first 6 months of open enrollment, and that's 7 million, which is what the Congressional Budget Office set as our bar. But when we think at HHS about our primary responsibility for outreach, we're thinking about the 29 states that are either the federally run marketplaces or those states that are partnership but are not doing consumer outreach. And so there are 29 states that are sort of left in that pool. And if you look at those 29 states, it won't surprise you where we're going to be spending most of our time. It's going to be those states that have the highest number of the uninsured. And this is, you can look at the census data: Texas, Florida, Pennsylvania, Arizona, Georgia, Michigan, right? So we know that actually if you look at the whole country and look at the 18 to 35-year-old demographic, we know that 1 in 3 uninsured 18 to 35-year-olds live in 3 states: California, Texas, and Florida. And we got 2 of the 3. So we're thinking very hard about how do we think about those states in particular and what's going to work to reach folks in those areas. So how are we going to do it? So this is a bit of our playbook here of how we're going to reach the uninsured. It's going to be a combination of paid, earned media, and partnership. You can lift up any newspaper and know that we're a little short on resources, and so we're trying to make our dollars stretch as far as possible. So our primary tactics here are really on the earned media side. And we have a few people who can garner some press coverage, so that's helpful. So we're thinking not just about national media outlets, but really about the papers that everyone reads, their local newspapers and their regional media, and thinking about how can we penetrate down there. Well, obviously, because we're thinking about the 18 to 35-year-old cohort, digital media is going to be extremely important for us. So we're trying to leverage what we can for social media to disseminate content. Specialty media, we know, again, as I mentioned, the percentage of Latino and African American populations, so we want to make sure we're reaching into that specialty media markets as well. And we want to have events to generate momentum, to drive coverage nationally. And then we are going to do some paid media and some partnerships. You'll see that more come this fall when open enrollment starts. But again, we're going to try to leverage things like partnerships and cultivating not just private and public partnerships as much as we can across the country, not just to be good partners as messengers, but these are the folks who are really trusted in everyone's community. So that's our playbook of tactics here. And if you drill down a little bit more, even on thinking about that young and healthy 18 to 35-year-old group, we've done a lot of testing about what do they want to hear, what is it about insurance that they need to learn, and what are those messages that really hit them, who is it that delivers those messages, and sort of, again, how do they get their information? So this sort of gives you a little snapshot. We know overall that people are going to make this choice based on price. So you'll notice that a lot of what you see in the messages are things like, it's a plan that fits your budget, healthcare that you can afford, financial help may be available, and again, even the last one, all information in one place about what it costs in one place. Every one of those messages has something about price because we learned over and over and over in our focus group testing that that's really what's going to be the deciding factor for folks. But we also know who they get their information from. Moms, number 1, in terms of when they're thinking about their health and their well-being. Girlfriends, yes. Moms, more important. So we're thinking hard about how do we reach your mom. I will say from personal experience, my brother is a musician in New York. Guess who bugs him to get health insurance? Right? My mom. He's riding him all the time. And in fact, has paid a bunch of his premiums for him, right? And we're fine with that. Give the gift of insurance. So we're thinking through of thinking about how moms, friends, as a physician, who do you trust in your neighborhood to deliver that message? But it's also building the culture of coverage, understanding why is this of value to some folks. They might say, I'm going to just pay that $100 penalty and leave it at that. That's going to be cheaper for me. But what they don't realize is they also like to ski, or they like to do some other sort of extreme sport, or they just like to drive to get to work, and they can get in a car accident and break the bank and go bankrupt. And we know that's what happens right now, and so sort of making that realization and bringing those pieces together for folks. We also know where they get their information from. We know most folks are on the internet all the time, but not necessarily about their health care, right? These are the folks who are not thinking about health care at every moment, so we need to break through in different ways and use different messengers to get there. And they like to watch TV, who doesn't? So another big part of the outreach effort is really once folks are like, you know what, I'm gonna check this thing out, health insurance is the right choice for me, we want them to also come and have a very good consumer experience. That's what folks are used to, right? If they go to Amazon or Travelocity or Kayak, they know how to use those easy interfaces online, and so that is what we are aiming to build. So I think you know earlier this spring we released our paper application. Again, we are hoping everyone is going to do this process online, but again, trying to streamline the process as much as possible. And then when they are online, to build a process that is as streamlined and as easy as possible. This is insurance. Folks understand that this is a complicated decision for them. They don't expect it to be like buying a plane ticket or buying a pair of shoes. This is about their health, and they take it very seriously, and as we have learned in focus groups. So we know that folks are willing to take time to think through this in a thoughtful way, but they need a good interface that can answer questions for them and provide information in an easy and understandable way, which is what we're trying to do online. And then for those who need additional assistance, we know the majority of folks will be able to walk through that process online, again, through the online application, but we are also thinking about how much enrollment assistance will be needed out there. Certainly by phone. That we opened, and I'll tell you more about this, our call center just yesterday, 24 hours, 7 days a week, 150 languages. So you're going through this process, you have a quick question, what does it mean again? What form do I need here? How did this question go? Pick up the phone. They can also web chat right there online, 24 hours, 7 days a week. But we know not everyone's going to be online. Some people are going to need to do all of this through the call center or do a written application, or they're going to need in-person help to go to their local community health center or their hospital or to a navigator. And then we're thinking through the partnerships of where can people go, where are there banks of computers that they can utilize to fill out the application and go through the process. So this brings us to the announcement we made yesterday. It's our first major down payment, I would say, with 100 days left. We launched healthcare.gov, or I should say relaunched healthcare.gov as the new consumer face of the health insurance marketplace. You may know and love it as the home for information about the Affordable Care Act, and don't worry, that information did not go away. It is still archived and can be found in different places. But we've really changed healthcare.gov over to be the home for those who are currently uninsured to find information about the health insurance marketplace. So you will see on the home screen here this green Start Now. We give people an opportunity to answer a few short questions about themselves, and at the end, we give them a tailored checklist on how to get ready. That's what this time is about from now until open enrollment. Learn, get ready. There are things they can do now, getting their paperwork together, understanding the value of insurance, and so that's what we provide them there. We also launched this entire site in soup to nuts in Spanish. Right at the top right, you can toggle right to Spanish and back to the English site. We've also prioritized everything in terms of frequently asked questions. The major bar across the center serves up to you the most frequently asked questions. If you are someone who is uninsured and looking for information, it should answer your most frequent questions right there on the front. Certainly has a countdown. It's a little out of date now. We're here under 100 days. But again, more information. Now, come October, the other side of the website, which is Get Insurance side, will be the more active side. This is where folks will come to fill out the application and then ultimately shop for a plan and enroll. Right now, on the right-hand side, you'll see the Get Insurance tab right now is somewhat static. It'll give you some specific information about your state. So if you live in California, it'll tell you Covered California is the place that is the marketplace for you. If you are in Alabama, it'll say you're in the right place, stay here. This is where you will shop come October. And here there's some infographics about why health insurance is important and about the process. Again, some just general information. And one I would say for this audience, know that we built healthcare.gov in a very open and transparent manner. If you want any of the code, any of the content, it is entirely open. You can pull it down into your own site and use it however you feel would be best for your organization to get the word out. So please do go, and if you want to chat with our consumer representatives right now or call our call center. I just did want to let you know that we did build this in a responsive design, meaning that if someone pulls this up on their smartphone, so if you want to do that, or if you get a little bored here, pull this up on a smartphone, it will look different than what the actual homepage. It will be optimized for both tablet and for mobile. So just a few more words about the call center. The number there, again, 24/7, 150 languages. And the reason we launched it, again, with the website right now is so that folks could get into a habit of, if they need to reach out to answer questions, because they are already asking questions, they can ask some basic things about, what do I need to prepare? How is this going to affect me? What is a premium? What is a deductible? What's this all going to be about? And we saw just from our early one or 2 days of our call center being open, these are the types of questions that we're getting asked. But it's helpful for us to learn over the course of the summer so that come October 1st, when we expand the functionality of what we're able to offer through the call center to enrollment assistance and stuff, it's good that we learn about how people ask the questions so we can continue to refine and tailor content. And I should say we're doing that same thing on the website as well. You will see that we're going to test different placement of words, different language. We have a pretty sophisticated analytics to make sure as you go through the website, if someone gets stuck on a page, we will notice. Obviously, you could give feedback on any page, and we take that seriously. We will be doing what they call A/B testing. So if you go to a site one day, it might look slightly different, and we're going to test whether or not people move through the site in a particular way, and we'll continue that through open enrollment as well. And then lastly, I just wanted to point out that in addition to launching healthcare.gov yesterday, we also launched a whole slew of new consumer-facing materials that might be helpful for you or your organization. If you go to marketplace.cms.gov, you'll find a lot of resources, whether it's you want to join an educational session, a Marketplace 101, that's for you or members of your organization. If you want to get a poster, a fact sheet, a brochure, an op-ed, a postcard, a consumer checklist, any of the stuff, it's at marketplace.cms.gov, and that was all released yesterday. And you can imagine we did that to make sure all of the language and the content was all synced up. But there's a lot of new information that you should go and check out there. And then I just wanted to end by sharing with you a little bit about what's coming for the rest of the summer. So we launched yesterday. Today we're doing a push on our Spanish language site. And consumers, again, can continue to sign up to get email updates from us, fill out a few quick questions, get a tailored checklist. And you will see this same theme over the course of the summer as we do events in person. Our regional offices are going to be doing a lot of events in person at different locations, whether it's at community health centers or other places, again, to start to raise awareness about this. And you will see over the course of the summer that we are going to also be working with our partners and continue to have conversations with everyone across the country, whether it's pharmacists or hospitals, or as reported yesterday, some sports leagues, to help us connect with the folks who will ultimately benefit from the law. As Gary mentioned, a lot of the summer will also be about training for those who are going to help folks in person, and awarding our Navigator grants. In August, we'll also open the call center that is specific to small business. The call center that's open right now is consumer focused, though can answer some basic questions about small businesses, but the small business focused call center opens in August. And then we ramp up to October 1st, and the first day of open enrollment. I think that's when you'll see us, as I mentioned, do more paid advertising and certainly more events and put our partnerships into full swing. So I'll stop there and be happy to answer questions. Thanks.
I'd like to ask the rest of us to come up too, Mike and Gary, and while they're taking their seats and getting their microphones put on, just a reminder that we're going to have some roundtable discussion among us. Actually, I guess it's not quite a roundtable, but some discussion among us, and then we'll be opening it up to questions and comments from all of you. And maybe I'll just start from up here and turn to Mike for some initial thoughts for this part of the discussion. There are a lot of issues that we heard about this morning, many of which came up with Medicare Part D as well. Important policy decisions to make with the goal of getting good coverage available at a low cost, many systems issues that need to be considered in terms of exchanging information, supporting decision making, and making the enrollment process as smooth as possible. Many issues as well around startup, things not working quite as well at first as they might over time. And Mike may remember a lot of the work that we're doing around looking at wait times at the call centers and the heavy load that hit the websites and so forth right when enrollment and actual coverage began. But there also are some important differences from Medicare Part D as well. For example, as you heard from Mandy, a big emphasis in this program on young, relatively healthy people, somewhat different, one might say, from the Medicare population. Also dealing with small businesses, which is something that we did not have to do. There are also some differences in terms of how this is fitting in with existing coverage. There are some people, excuse me, an important number of people who will be moving from coverage now, either in the individual market or in small business plans, over to the new marketplaces. But it's not, I think, quite in the same nature or scope as the 7 million Medicare Medicaid dual eligible beneficiaries who all switched over on one day with Medicare Part D. Also some other technical or logistical differences that may end up mattering. For example, there's a couple weeks lag between when people enroll in their coverage in the exchanges and when that coverage actually begins. We had no such lag built into the legislation for Medicare Part D. So, Mike, I wonder if you could start this discussion just by commenting on what you see as some of the big issues now in light of some of the similarities and differences from Medicare Part D before.
We're in a predictable period where the struggle is to believe or not believe. On one hand, one party will, in the political backdrop, will want this to seem like an unavoidable failure. Then the other party will want it to feel like an absolute certainty. This really is the same thing that played out in 2006, except the roles have reversed. So much of this, one of the things that we know with certainty is this is going to play out. The premiums in this struggle to try to keep, to believe or not believe, there's a tendency, I think, for the premiums to be viewed for one side to play it as badly as it could be and the other side to play it as good as it could be. It will be what it's going to be, and it will play out. There will be on one side people saying the technology simply isn't going to work, and there'll be those who say the technology is just going to work great. The technology on October the 1st, and then again in January, it will work or it won't. And there will be problems, and they will respond or they won't. And this is a very dramatic moment, and how it is actually responded to will make a difference. And so the preparation that's being made as to how they can, how they should respond. How will the public respond to this? I think is still an unknown. So I think we're in summary, I think we're in a predictable period where this is playing out in a political backdrop, but underneath that, there's a series of logistics that are being put forward that will in fact play out, and we'll have a chance to see how that occurs, and we'll also begin to see what the response is, because that's obviously what I think now the implementers need to be thinking about is what will our response be to the problems.
Go ahead, Gary.
And I would just say, you know, on any given day, I could read a story that says that October 1st, no one's going to show up, and on October 1st, 7 million people are going to show up. You know, and so we won't have any people coming to us, and there'll be so many people coming to us that we won't be able to handle it. You know, and I think we've worked very hard to learn some of the lessons from what happened with Part D, but as you pointed out, this is a little bit different. This is an open enrollment period that goes over a course of 6 months. There's going to be a period of time from when people first come on and apply and get connected with an insurance company and pay their premium to when coverage actually begins. So it's not going to be a one-day phenomenon. It's going to be a phenomenon that takes place over a course of time, and we will have the opportunity to make corrections and make improvements, you know, as the process continues. So, you know, I mean, I will be excited and delighted if we have a tremendous, you know, number of people who you know, come to our door on October 1st. But I won't be that surprised if that doesn't happen, and if it takes a little bit of time for, you know, for that to build and to grow, you know, over the course of the open enrollment period.
You mentioned, Gary, that you all have been looking at some of the lessons from Part D, and both of you referenced Part D in your remarks. I wonder if you'd say a little bit more about what kinds of lessons you've drawn, not from the standpoint of how there will be startup issues and it is possible to work through those to an ultimately successful program, but more from the standpoint of what about it in terms of things that happen with Part D, in terms of building the systems, in terms of the education outreach, what seems most relevant to the plans and the activities you're implementing now? So
I think a number of the people who are directly responsible for a lot of the IT work were involved with the Part D experience and have learned some of the lessons about scalability and flexibility. And what I keep hearing from the veterans of that experience is, you know, October 2nd, it's all hands on deck. We can all expect to be, you know, jumping in and solving problems and doing casework if that's what's necessary, and just, you know, be prepared for the fact that, you know, things aren't going to be absolutely perfect, you know, right out of the gate. And I think we're trying to, you know, to communicate that, to make sure that people understand that, you know, this is big, it is complicated. But you know, over the course of time, you know, we will get there, and we are mobilized to try to address whatever issues are going to come up.
I think on the outreach side, we certainly have taken a page from your playbook on the partnership piece. I think that there was a lot of partnerships built, as you mentioned, with not only the pharmacy community, but hospitals, the provider community, and others. And we are certainly looking at that and have learned from that about, and I've heard Governor Leavitt mention before about how important those relationships were to build early and often, and so we're thinking about that all the time and how we can mobilize the folks that want to help, and how can we coordinate all of that great effort that is out there. So that has certainly been something that we've learned from, and we have many extremely competent career staff that went through the whole Part D experience and know how to do this. It is a different population that we're thinking about, but at the end of the day, it's still people, and it's still those relationships, and it's still working with communities, and it's still thinking about who are the trusted folks for that group. So there's a lot of lessons learned that we are thankfully taking from how you set up that work. And I know Governor Leavitt, you know, certainly. I'm sure you'll talk about this, got on a bus and went to different communities across the country, and we're thinking about how to, you know, touch folks in that very tangible and local way as well.
Mike, did you want to comment?
Well, I will just maybe recall some of the scope of what we were doing. I think that's important to see it in context. We started actually, I guess about 6 months before actually working to build relationships with partners. We did an entire national tour.
The bus tours were early 2005, not...
Oh, I guess that's right. So it would have been it was almost 15 months that we were... I went to 119 cities myself. Wow. I did 98 cities and did 119 events. The bus traveled over 600,000 miles. We had 50,000 events that we had ultimately orchestrated, and it was really in 3 phases. The first was reaching out to partners, and this is where we would go to, we would meet with city councils and mayors and hospitals and pharmacies. One of the things I found fascinating is that we would bring together groups in these communities, and many of them had never met one another before. And yet they had to operate in a network now of caring to try to bring people. It was people in nursing homes and in care centers and in hospitals and in. It was and so we spent a lot of time literally working to build partnerships and then to train people. And then the second phase really was about training them to be prepared. And then lastly was enrollment, where we actually started bringing people in and helping them to enroll. And what I think ultimately was created in those first 9 to 12 months was a network of caring, of people who were going to step up. It was the moms, and in this case, it was for the most part the children.
Children, that's right.
We were reaching out to children to say, if you have an adult, or if you're an adult and you have a mature parent or neighbor, help them. I remember in Chicago, Mayor Daley had a system where they would send neighbors to check on neighbors when the temperature got extreme, either hot or cold. And he deployed that system to go into the various communities and to say, have you done your Part D yet? Because if you miss it, it's a problem. So it was not just deploying a system, it was deploying a network of systems and enlisting this, and that took time to build. It didn't just happen.
I lost track of how many of those bus events and other events I did around the country. I'll try to count them up as well, but it was a lot, and that was a critical way to build up support. One of the, for enrollment, and I think one of the things that we learned in that process was that when you get down below the level of national politics to the level of local officials, non-government organizations, neighbors, as you said. The questions are really not about what's the politics of all this, but what does this mean for me and for the people that I care about? And we got a lot of feedback early in terms of how we were thinking about designing the tools, designing the later outreach and support efforts that were coming, that really encouraged us to focus on just the facts and making them as relevant as possible to each individual person signing up. And Mandy, that sounded like a big theme in what you've been doing. Now, you mentioned the resource issues, and then you all didn't do these same kind of local community building outreach efforts, but it sounds like you're aiming for some of the same goals. One other thing I'd like to hear your perspective on is that while we built up a lot of networks locally, I think as Mike said, that was absolutely critical for the outreach and support efforts to help people find out about the program. Compared to 2005, 2006, there are a lot more social networks today, a lot more communities building up online, particularly for the populations that you're interested in reaching. And while that was a component of the outreach activities we did, it sounds like it's much more prominent here. And I wonder if you could comment a bit about all of this, these sets of issues that we've raised.
Yeah, no, I think we are very lucky in some ways, is that the fact that we can utilize social media and the tools that are at our disposal on that front to get into communities in a very deep way without having to expend a lot of resources. And so that's very lucky for us, and we're certainly leveraging as much as we can. But it's also about making partners with those who know how to build communities both on and offline. And so we're thinking about that in multiple different ways. But I think when you think about our earned media efforts and our paid media, it will focus a lot on digital advertising, even just search term optimization, things like that, very basic stuff. But then also, are the tools available on a smartphone, on a mobile device, and can folks be doing this on the go? And so we think a lot about that and building things in a way that are, frankly, what the younger cohort expects them to be like. So I think, but we need both. If we only focused online, we would be certainly missing the boat because healthcare is so personal. it can't just be something that they hear alone in social media. I think we can reinforce, and I think that can help start and elevate the awareness. But I think to truly do the breakthrough is we're going to have to get folks from multiple places and make the personal touch. It's going to, and I think that's really going to be like, my friend signed up, or I heard from someone close in my sphere of influence that this happened, not just necessarily online. So we're definitely thinking both.
The one thing I would add is that a lot of the activity is really being generated out of the 10 regional offices, and we get a list every week of the different events and the different meetings and the different outreach activities that are happening out in the regions, and there's a lot of activity that's going on there. And the other thing I would say is that although it may be difficult to detect from where we all sit here in Washington, whereas we've acknowledged it's a lot about the politics and the policy. There is a lot of excitement about this out there. I mean, we do have groups coming to us saying, what can we do to help? How can we get involved? How can we reach, our people and our community? Because people do recognize that this is, an extraordinary opportunity for people who have never had the experience of going to a doctor and being able to take out a card, from an insurance company to say that that visit is going to be paid for. Not only to have that experience, but to have help, in paying, for the premiums to be able to do that. So there is a lot of, interest and excitement at the local level, and I think that the strategy that we followed, and as you pointed out, Mike, we'll see how well it works, but the strategy that we followed is to say, let's really gear up our efforts in terms of outreach and education close in time to when people will actually be able to do something, and make sure that when we are sending out these messages, we're giving people, at this point in time, the opportunity to go and see a checklist, get ready, get prepared, and then, as the effort builds, we'll actually be able to, go online and fill out that application and get enrolled in coverage.
I'm struck by some notable differences. I think they've been mentioned, but worth highlighting. The population that we were the most concerned about were those who were fragile because they were old and may not have had a support system. And this was clearly going to be a very hands-on kind of enrollment process where you were looking at someone in the eye and talking with them. They needed to bring their bottles of prescription drugs to make the decision. I mean, the whole goal was to get them to, first of all, to get all the bottles of prescription drugs and put them on a table so that we could determine what drugs that they ultimately needed to take. Now, I enrolled countless people online where they would do the same thing, but in many cases, that was a process that needed to be done in a physical way. The most challenging marketplace that you're focused on, as you described it, were young people with, in some cases, language barriers. And the big question is, would they care? It was clear that people who were taking prescription drugs cared. And the question in this group is, can you get those who are the young and invincibles? Those are different markets. And so it's quite understandable to me that you would approach that group differently than we chose to approach the big market, a big worry group that we had to deal with.
Could you maybe say a little bit more about how you're experiencing those differences in perspectives? What Mike said about putting pill bottles in front of you and then checking to see what those drugs cost at your pharmacy in different plans was what seniors told us in those early meetings that we did and the meetings that we did with the groups and leaders who were involved in activities to support seniors. In our focus groups, we talked some in our early focus groups about things like, well, we could tell you about your probability of needing, say, a drug for high blood pressure or high cholesterol or a serious infection or something in the coming year. And not a lot of interest among the people who were Medicare beneficiaries in hearing about those kinds of hypotheticals. And you're dealing with a group that not only is pretty healthy, or at least many of the people you're targeting are not only pretty healthy to begin with, but may also have some of those same reactions.
Well, so I'd say a couple things to that. One is you have to remember most young adults had coverage recently. So they remember. So this isn't an experience that they didn't have, and it's not, when we ask in focus groups, not that they don't want insurance. It's always seems out of reach, unaffordable, unattainable to them. It's just not. It's not offered by my employer. That's just not something that it's possible for me. And so it's not. We haven't found that it's something that is not of interest. It's more. It's showing them that it's possible for them. Showing that, and frankly, a lot of folks have tried to get insurance and either been locked out, priced out, or what have you. So it's needing to show folks the value of insurance and why it's important, but that it's attainable for them this time, and why is this different? Why is October 1st different than September 15th for them? And so we're thinking a lot about also just showing that this is a new moment in time is important, but I think you're absolutely right. We're spending a lot of the summer just talking about the value of insurance and why that's important, particularly to a young group. And as I sort of mentioned the example of, folks like to, ski, they like to drive their car. They never know when something, could happen. And the peace of mind that comes with that and the security that comes with that, folks, that resonates with people. That is a really deep emotional reaction to that we see in our focus groups, and that's sort of the message that we're focusing on.
Mark, there's one aspect of this that I'm going to be interested to watch, and that hasn't been talked a lot about, and that is we're here talking about the marketplaces, the creation of the marketplaces, the marketing that goes into bringing people to use those. But there's going to be a whole series of atmospherics at that moment that will have a defining quality. There's 41 million who are uninsured. The target here is as Mandy described it, was to get 7 million, and they've targeted a series of those groups through the exchanges. But there'll also be a whole series of Medicaid enrollments going on at the same time. And then the other 260 million people who have insurance are also going to be experiencing a profoundly different place than they've had before in terms of the kinds of benefits, the way they access them, the potential cost of those. I would be,
maybe some alternatives that would be,
and some alternatives that they might not have otherwise had. And so I think it'll be interesting to see how that affects the environment in which this plays out.
Definitely lots to watch. Maybe just following up too on the discussions that you've had in the focus groups with individuals. Our experience, I know my experience, and I think Mike's might be similar, is that this level of engagement got people to look closely, to go online to figure out, okay, what is it going to cost me? What am I getting for that? And then they made a decision, and it was a decision, and hopefully in most cases it was well informed. And there were a number of seniors who weren't taking any or many drugs, who thought that the premiums, we had fairly low premiums, lower than expected. Many of them made the decision, well, I'm not using that many drugs right now. This isn't that much money to spend for that kind of peace of mind that you were talking about. Do you have any sense of what that number is and what the tipping point is for many of the people that you're looking to enroll?
No is the short answer. I think we know that price is the ball game for them, but I don't think we've ever, because every personal situation is so different, and where they prioritize that amongst their family budget is so different, and that's what makes this so challenging, right? You can imagine a young 30-year-old with 2 kids thinking and prioritizing health insurance for themselves differently than maybe a 30-year-old who does not have kids. Let's just use that as an example. So it's really hard to come up with one number that's going to work for everyone, and that's I think we're going to have a lot of learning here to understand the folks that do go through the process and what works for them based on their income, and then learn from that, and I think build on that and get folks in. But similar to how we're going to have a very heterogeneous folks that we need to reach out to, it's going to be different. That number is going to be different based on their circumstance. But what we do know is that we've seen in focus groups is that there is a lot of politics out there, and people react to those politics. But when they get down to a real benefit and a real number for them, that goes away, and they go, that can work for me. We literally have folks say, what, I don't agree with the law, and I don't agree with the politics, but that can work for my family. And I think that's what we're after, is just to serve up the most accurate, timely information we can, and to get people to take a look. And then I think it's going to be something that'll fit for their budget.
I also think that for the people under 30 who are healthy and don't go to a doctor very often and so forth, the catastrophic plan should be attractive to them and should be affordable. That will protect them in the event that something unexpected does happen in terms of an accident or a diagnosis. As Mandy mentioned, I mean, probably a lot of us have had. I've had that same conversation, with my kids, when they got to be past the age where they no longer were on my coverage, but were just starting out and didn't have coverage through their employer, and made the point that if something terrible were to happen to them, that would have a devastating financial impact, on the whole family, and so it's very important. That's a very important thing to do. So I do think the catastrophic plan will be something that will be attractive to folks who don't have a lot of ongoing medical care, but just are looking for that peace of mind and security that they won't be forced into medical bankruptcy or what have you.
So we've talked about the individual decisions, and Micah, and you may have been just about to comment on this, but I want to build in something else too. We've talked about sort of the individual decision aspect of this. Something else that I recall, I wonder if it was your experience too, was that as the open enrollment period went on, there got to be more of a social aspect to this. Now, partly it was just, I think we gave more senior centers more conversation topics for dinner than anyone ever done, in terms of people comparing this and that plan, and how long they had to wait with customer support and things like that. But by the February, early March, I mean, there were a lot of people who had enrolled, and that kind of got to be more of a social aspect to it. Of everybody else has thought about this, I better do it as well. And then on top of that, we had the end of open enrollment period accompanied by a nice but firm message from us that if you didn't sign up now, you would get another chance the next year, but it was going to cost you significantly more forever. And that really led to a big boost in enrollment and participation towards the end of our initial open enrollment period, so that by the end of that time, this was kind of the coverage that most people on Medicare were, the vast majority of people on Medicare were using. And this seems like it's going to be a little bit different by the Secretary's predictions and CBO and so forth. It's 7 million out of a larger number. There are going to be a lot of very low-income people, particularly in states that don't have Medicaid, that may not sign up. So it seems like this is going to be more of could be more of a several-year process or a more extended process. I'm not sure if that's what you were going to comment on.
Well, that's exactly what I was going to comment. I think one difference is that we saw our interest expand as we got further in, as I suspect it will in this case, just because there'll be more discussion. But a major component of decision-making was that if you don't act on this now, next year it's going to be more expensive. And it will be more expensive for you forever, not just next year. And I personally think that's a plan design flaw that ultimately has got to be fixed. Otherwise, it just puts people in a position to say, why should I buy until I get sick? And I don't think that was either of your choice. I just think that's ultimately one of the learnings that's going to come out of this, that you have, that's part of the responsibility of having insurance. You're rewarded if you have it for a long time, and if you wait, it's going to cost you more. And that was a very big feature of our it was as you said, a stern but hopefully well-delivered reminder that there were consequences for not signing up.
And I know you all have a lot to think about between now and near the end of the open enrollment period, but have you thought much about how to convey not just the decision that people need to make now about protection versus cost for premiums, but the consequences downstream?
No, I mean, I think you're right that it's going to be important toward the end of the open enrollment period to communicate a sense of urgency and a sense of now is the time. And it's true, I mean, you could make the decision not to buy and sort of wait till you get sick, but you will have to wait till the next year, and whatever costs you might have over that intervening period are going to be yours to bear. So I think fundamentally, I sort of come back to what Mandy said, which is it's our job to communicate the value proposition to people, that this is something that is important for them and that is affordable for them. And if we're successful in doing that, it is something that people are interested in and want to have if they feel like it's accessible and it's affordable. And so that's really what we're hoping to communicate.
I'd like to turn a bit to some of these startup transition issues. Those have come up during the course of our comments. Mike, you mentioned some of them at the outset, and I'd like to maybe start this by asking you to talk a little bit about your strategy and our strategy for trying to deal with some of the problems that arose with initial implementation, things like the data not flowing through, people who had signed up soon after showing up at a pharmacy expecting the prescription filled, and some of them having difficulty. And when you're dealing with millions of people, even if it's only 1-2% that are having problems, that's still hundreds of thousands and still lots of news stories and lots of real concerns for Americans who need their health care. And in particular, I wanted to ask you about one of the things that you were emphasizing throughout this process was needing to be able to show progress, that we were identifying on top of what the startup issues were, and we had numbers or clear evidence to show that we were on top, and that we were showing improvements in those numbers. It wasn't all going to get fixed overnight, but we were showing improvements in those numbers over time. We talked about this before, but I like to quote Mike Tyson, that famous manager and executive, who said that everybody's got a strategy until they get hit. Yeah. And you can't anticipate every problem that's going to happen, but I think it is probably safe to say that there are going to be some real issues that will be noted by the press, the public, others, as this gets going. But the trajectory there was something that seemed very important. Maybe you could comment for a few minutes on that. I don't want to put Gary, Mandy, you all on the spot too much, since you haven't lived through this yet, and it's hard to know exactly what the issues are going to be until you actually see them. But I would like to ask you all about, should we call it contingency planning or response planning? We'll turn to you all in a minute.
Well, we had worked for 15 months up to January the 1st of 2006, and so I think on the Monday following, I think it was actually the 3rd, by the time January 1st was a holiday. The 2nd, I think, I've forgotten the day of the week. But when we met, I remember looking around the table, and we were all just sort of taking one another's pulse to determine, how does this feel to you? What's happening? And it occurred to me at that moment that we did not have a very good system of being able to measure how well we were doing. We were in a place where we had, I've referred to it as the fog of war. There were so many things happening simultaneously that getting a clear picture of whether or not we were making progress or not was something that we did not give proper emphasis to.
It wasn't only important for us and for sort of internal tracking. We did a lot of numbers internally, but also for the public and dealing with people who are raising
that's exactly, well, and it began to, then it just began to snowball. You could just feel it. At the first 3 or 4 days, there were episodic reports, and then it began to create more momentum, and there were more, and there were more, and then the news media began to pick up on them, and they were all very personal stories, and it just began to feel as though that nothing was going well, when in reality Mark would continue to report to people, look, we've had millions of prescriptions filled, and there are some who aren't, but there are millions of prescriptions who are, or people who are getting their prescriptions filled. But we realized we did not have the proper kinds of metrics to demonstrate that. And so we spent a lot of time developing what should we now be measuring, and developing those measures And within a few weeks, I think we had developed a series of very responsible measures on how progress could be, and we began to report them in a transparent way. And it was not just helpful, as Mark suggests, for us in managing it, but it was important for those who were trying to determine the same thing: how were we doing? And then, during that period, it was playing very much. I mean, we were again playing with a political backdrop. There were people who really didn't want this to succeed, or didn't want to admit it was succeeding.
It was an election year.
That's right, and there were people who, wanted it to desperately, and so they were there was a battle of trying to define. It was a spin battle going on as to what all of this meant. And we identified 6 very significant problems that we had to deal with as a response. And the number one problem was the systems weren't translating the data accurately. It was when I say accurately, a lot of work had gone into it, but we were now testing where the mistakes were in a live fire way. And that involved the governors, because it was Medicaid systems that were, and they were agitating. They were feeling both financial pressure and political pressure because they had a responsibility. I went to 20 states in 13 days and met with governors and met with state legislators and met with people to say, we own these problems. We're going to find them and we're going to fix them. We just need you to be patient, and here are the things you can look at to determine whether we're making progress. We went to Congress and had the same conversation. But again, going back to your point, having a series of measures that would allow us to transparently and accurately reflect the degree of progress we were making turned out to be a critical lesson.
So in terms of those metrics, I mean, people are going to care about enrollment, and the number out there is 7 million, so you can expect a lot of comparisons to that as things go along. But to Mike's point, for the problems that we were identifying, these were things like wait times for people who were calling, failure rates or cases where information from states about Medicaid eligibility wasn't reaching us properly and wasn't matching up with what we were hearing from plans. Complaint rates to the plans, to us about plans. Typically, these were things like, my data is not up to date and so forth. And while Mike was out meeting with those governors, I was working with our teams here and around the country on both tracking those numbers and making sure that we had steps in place that we believed were actually going to make credible, measurable progress on addressing these kinds of issues. I think that the issues for this program are going to be different, but they're going to be there. And if you have some, again, not to put you too much on the spot, but this is coming, and you are going to be in some.
I mean, I would start by saying, first of all, I am really looking forward to the day when we are judged by how well we've done, as opposed to speculation about how well or badly we will do, right? Because now it's very easy for people to say, oh, it's going to be great, or oh, it's going to be terrible, and and kind of hard to respond to that, other than, by saying, oh, I think we're doing fine, So I am really looking forward to the day when, now you might have me back here on October 15th and ask me whether I still feel that way, and we'll see. But I take some real lessons from what you both have said, and I think the most important lesson is, you get through it. It's hard and it's a struggle, and there are problems, and you work them, and you travel around to places, and you talk to people, and you get on top of them, and 7 or 8 years on, it's a program that people rely on and count on, and is of tremendous benefit to them. So I think the same thing is going to be true for us as well. In terms of metrics, clearly we are going to be looking at all the sorts of things that you mentioned. Enrollment is a big one, but it's also how are we performing in terms of call wait times and complaints, and how many people are able to get through an online process that's relatively simple versus how many people default to some kind of paper-based process where they have to, actually, scan something in and send it to us, or God forbid, send it to us in the mail. And all of those things are, we're working to make all of that work the best we possibly can. But, there are going to be some people, as Mandy mentioned, sort of the single person, no dependents, who's filed a tax return, doesn't have employer coverage. They're going to be able to get through this thing pretty easily. There are going to be other more complicated situations where you have a family where the kids are eligible for CHIP, and then somebody else is eligible for tax credits, and then more complicated mixed situations where it's a more complicated process. Clearly, we will, I think we are all, as I think I mentioned before, I've heard it enough times from folks who lived through Part D, it's going to be all hands on deck out in the regions. It's going to be all hands on deck here in Washington, to address those problems and identify them and do our best to fix them.
Not to add to the complexity, but obviously we have responsibility for not all of the country. Say that. So there's going to be metrics that are coming from other places that I think will also be a key piece of this and how we put that all together. And I think the important for us will trying to be to separate out the anecdote from the actual from the data really, because there's going to be the anecdotes and. In this town in particular, anecdotes are very powerful, but we have to make sure that we're being as true as we can to really understanding where the top priority issues are and reacting to them and making course corrections as we need to. And I think we're putting analytics in place around the IT systems, particularly as folks go through the process online and also with the call center, but that will really be how we data mine in order to make sure that we're understanding that these aren't anecdotes and understand where the real issues are so we can tackle them first.
And I would just say one other thing. I can guarantee that on October 1st and 2nd and whatever, there will be stories saying this is a great success, and there will be stories saying that this is a terrible failure. And I can even tell you who will be making which statement and which quotes there will be. That's easy to
same
predict.
Again in early January.
Same in early January. I could write them now. And I think that one of the things that I try very hard to communicate to my staff of incredibly dedicated, hardworking people, who've come here from all over the country to work on this thing because they believe that it's important and that it's going to benefit millions of people. So you just have to keep your head down and not pay too much attention to that. People are going to write what they write. They're going to say what they say. And it's our job to stay focused on on what we need to do to make this thing work and to be a success, and so that when we look back from with the luxury of a little time and distance, we can look back and say, okay, this is where we succeeded. This is where maybe we could have done better, and view it from that perspective.
It's a good perspective, Gary.
Mike, did you have a comment to add to that?
Well, I was just going to remind us again that the conversation we're having today, one we're all vitally interested in, but in a narrative that's this big, what we're talking about is going to be this much of it. That there will be a narrative being a contribution on what's going on in Medicaid enrollment. And there will be, at the same time, 260 million people who are subject to renewals that have a whole series of new dimensions to them. And so the narrative about health care reform, I don't believe will be just how are the exchanges working. It will be how is the Affordable Care Act implementation working, and how will we begin to write that narrative. When I was governor, we had the Olympic Games, and I've often said to my colleagues, this felt a lot to me the same. It was undoubtedly going to be the piece of my public service that people would look at and say, if it worked well, good job. If it didn't, you were a disaster overall, no matter what else I did. I think there are components of this that, Part D, obviously that will play out. How will that narrative be written? The thing I learned in the Olympic Games was that in the first few days of the Games, events would begin to brand what people looked at. And I think that's one of the things that in our case, in Atlanta, for example, it was the transportation. In our games, it turned out to be something different than that. But there'll be early branding moments. What we're talking about today will be a significant and important, but only a portion of the entire narrative.
I would just say, just to be real clear about one thing, because of the Supreme Court's decision making Medicaid expansion optional with the states, we're going to see some pretty significant differences in this country from one place to another in terms of access to health care and access to health insurance. And we are going to have an opportunity, assuming that we're successful, and I think we will be, we're going to have an opportunity to take a look at that in a year and see what difference it made, the choices that were made at the political level to do one thing rather than another. And that's going to be a pretty profound difference and a pretty profound choice that we get to make every couple of years about what kind of country we want to be. And so I think that's going to be a very interesting element to this as well.
I think that's actually an important element to emphasize, and Mike talked about the length of this narrative around healthcare reform broadly. You did as well, Gary. My feeling about the Part D implementation experience was that it was a one-season story about getting the program from not in existence to up and running and reasonably clearly established with 25, 30 million people getting coverage, the rest having employer coverage that wrapped around, and some of them have moved over time. There have been a few shifts, but the basic program was pretty well established and people were pretty well signed up for it in 1 year. So one relatively contained narrative. This one's going to be a longer and more complex one for the reasons that both of you have emphasized. We're talking about a minority of the uninsured actually enrolling in the exchanges in the first year. Big differences across states because of their very different approaches to Medicaid, and quite possibly because at least somewhat different ways that the exchanges might play out. So this is going to be a much longer narrative, and those key events, Mike, are going to happen over a longer time period as well, and the ones that happen during this open enrollment period, I think you're going to have to look at as part of what's going to be an ongoing and evolving process, perhaps much more so than Part D was. So I'd like at this point to open this discussion up to questions and comments from all of you who are here. I think have a couple of people with microphones around the room. So if you've got a question or comment, please do raise your hand, and we'll try to get to as many of these as we can. Maybe start in the back.
Hi, my name is Michelle Sternthal. I'm here with the March of Dimes. And I first want to say we really appreciate all the work at CMS that you've been doing to further the implementation. We're really excited about the benefit this is going to have for women of childbearing age and children. One thing I would love to hear your thoughts on the relationship between the federal government and states in oversight regarding things such as the non-discrimination clauses. Or provisions of network adequacy. These are things that we've been trying to wrap our heads around to make sure that there are adequate protections for some vulnerable populations. And knowing that it's hard to get into the details, what mechanisms have you put in place already in working with states to assure that if there are, for example, problems in terms of the essential health benefits, that there is a venue for consumers to go? And this could be, I know there's a challenge between federally facilitated exchanges and state-based, but what has been put in place already and working with the states to assure compliance with these really important provisions of the ACA? Thanks.
So thank you, it's a great question. So generally speaking, as I think I mentioned before, we have tried to build on the traditional role that states have in terms of insurance regulation. And so, but network adequacy and non-discrimination are two elements that are required to be reviewed for qualified health plans to be sold on the exchanges. So in the state-based marketplaces, I mean, they're responsible for doing that. On the federal side, we really look to what state law and practice is, and if they have a system where they do review, and some states do, we rely on that. If they don't, then we're doing those reviews ourselves. And I would say that in all cases, we are in kind of very regular contact and communication, both with state regulators and with issuers to make sure that those requirements are being met. And in terms of going forward, consumers will have the ability, I think, to do what they do today, which if there's a problem, complain to their state insurance department, but they also will have the ability to come to us and bring matters to our attention. And then depending on what the situation is in terms of what the state is doing, what we're doing, we'll either handle those complaints or we'll refer them back to the state. So it is a kind of a matrix approach, I guess. But as I said, it's one that we try to rely as much as possible on state enforcement, but we're there as a backstop if state enforcement isn't happening.
Sorry, other questions? Over here.
Sarah Hansard with Bloomberg B&A. Hi. Gary, can you talk about, I understand the Secretary talked yesterday about HHS is now negotiating with plans, whereas previously you'd said that you were going to accept all qualified plans.
So we haven't changed our policy in terms of accepting all qualified plans, and at least initially in the federally facilitated marketplace, we are accepting all plans. What we are doing is, as the benefits and rates have been filed with us, we are reviewing them, and we're doing what the actuaries call an outlier analysis. So they're looking to see if there's anything that is out of sort of the norm. And then if we find that, we can communicate back to the issuer, we can communicate back to the state insurance department to make sure that, first of all, that there isn't a mistake or a problem or something was, in terms of the way they provided the information to us was wrong. And then, it really, rate review authority does really rest at the state level. So we just want to make sure that we are communicating that information and what we're seeing, making sure that the states are seeing the same thing, and then they can take it from there in terms of the process in many states is rates are filed and then there's a period of time before they're actually approved, and some states actually have authority to disapprove rates and other states don't have that authority, but there is kind of a process of give and take where changes can be made to the rates. So that's, we're again sort of working with our state partners to make sure that everybody has the same information, that they're seeing what we're seeing, and that we're doing what we can to make sure that the rates that ultimately go into effect are the best for consumers.
Other questions? Are you over here?
Yes, thank you. My name is Renee Cohen, and I actually am here representing Senator Cardin from Maryland. First, I'd like to say that it was wonderful to hear the comparison between the the Medicare D program and what we're trying to put in place, because it really, for those of us who went through that, it makes it all seem much more real and down to earth as to what we have to look at and what are some of the differences. But there's one issue that you didn't talk about and I'm interested in, because we in Maryland would like to kind of take a dog and pony show like you have here, go around the state and talk to businesses, small businesses and medium-sized businesses, and you haven't really talked about that, and I don't need you to do that, but can you tell us where we would get the best resources of individuals? Are we talking about IRS people who could best address issues that the small business people are concerned about? So that's other than the that we talked about, other than the 7 million that you want to be insured. It's all that other group of people who either are insuring their workers, thinking about another way of handling it, would like to insure their workers, and all the issues, and some of them are not happy about what they're going to have to be doing. So,
So I
That's it. Thank
think
you.
that the Small Business Administration is a really, kind of central place across the administration that is doing a lot of that outreach and that effort. And I know we meet with Superintendent Mills on a regular basis and have partnered with them to reach out to sort of their natural constituency, if you will. And they're doing that again through their regional offices and trying to get out a lot of information that's directed specifically at the small business community. And then as Mandy said, the call center that's specific for small businesses will be opening up a little bit later this summer, and that will be a source of information as well. I don't know if there's anything else that...
No, that's exact, and I'm happy to provide you the contact information of the folks at Small Business Administration.
But this is a good point, and we've talked about the breadth of the entire narrative. Another part of this isn't just the 7 million who are uninsured. There's a large population of small business owners who are looking to the day when they can do something different that will provide their, and I'm not talking just about not paying just paying the penalty. I'm talking about being able to convert from a defined benefit to a defined contribution and begin to use the exchanges as a means of satisfying the commitment they've made to their employees. There will be there are a lot of small businesses in that category, and so reaching out to them, I think, is important, and it's a very important way in which you can ultimately keep small business with their head in the game here, is to give them this tool. And I think they will be a constituency that will be gauging the success of this by their own experience.
One of the concerns we have is that we're going to meet with a lot of
Microphone.
people. So we want to try to prevent that from happening and getting the best team of people to talk to them.
Right.
I think it is your question hit on two issues that are, I think, quite different from Part D and the implementation that you're doing now. One is that we did not have to have as much kind of direct interaction with small businesses. Another is this issue of reliance on the states. I mean, one reason we're up here having such an extended conversation is there is turning out to be such a big federal role in at least these early years of implementing the Affordable Care Act. But you're right that these federal-state partnerships are very important. We had a lot of those issues around dual eligible beneficiaries and
large corporate plans.
And large corporate plans. And wondering if Manny and Gary, you all could talk a little bit more about how you see the outreach efforts, the awareness efforts for small business different than individuals. And you talked a lot today about the website that's up now, which I think would probably be helpful for small businesses too, but there is a lot of uncertainty there, a lot of questions, a lot of worries that premiums might go up and things like that. And it's a different audience than the individuals.
No, it is, but I mean, I also think that most small businesses today procure health insurance through the services of an agent or broker, and I think that's going to continue to be true, as we move forward into the end of this year and into 2014. And we've done a lot to work with the agent broker community and the trade associations and so forth to make sure that they will be able to assist their small business clients in understanding, what the options are and what's available to them. So I think it's a little bit different from the individual situation where you're reaching out to people who may not have thought about health insurance very much, may not see a need for health insurance. I think every small business owner at least has some awareness of this is a choice that I have to make. Do I provide this as a benefit? Do I not? What's the cost to me? What's the benefit to me in terms of recruitment and retention and a healthier workforce and all of those things?
And there's an existing network of agents and brokers that have already been helping them out with those issues that just need to come to the new marketplace experience.
In fact, I would say that should be a big part of the solution to your problem. I think that the senator's doing a good thing by reaching out, but they really need to harness the existing navigator community, which happen to be agents and brokers, and use them as a conduit to be able to supply that information to so many people.
It's very very interesting because I'm married to one of them, and we have some very interesting discussions in our household where he asks me why I'm trying to do him out of his livelihood. But what his interpretation, and this is a gentleman who's been in the business for now a second generation, and he's saying that what he's learning is that there's going to be very little reward for him to continue to do that, and maybe there needs to be more information out there about that from his network in Maryland.
About how this actually works for agents and brokers.
Yeah. So we think that it's important, whatever we meet with, when the senator meets with, when going out to visit with people, it's still important to get information out there, but we'd like it to be as positive as possible, and so maybe we could get a little bit more help about that.
Be happy to do that.
Okay.
And I think the one thing I wanted just to add on the business outreach generally, obviously for businesses that have 50 or less employees, this new marketplace for them, and we need to have folks understand that that's coming, and there's a particular amount of information we want to share about that. But then there's and that's 96% of businesses. But then there clearly are a lot of businesses that fall between 50 and 500 and 500 and above, and having them understand they're grappling with some of the issues around this. So even if they're not going to be in the small business marketplace, they have questions and are making decisions. And so that's where particularly the Small Business Administration is really helping us with some of those even I would call medium-sized businesses to help them walk through some of the implications of what the Affordable Care Act will be for their businesses.
I do want to go on to the next question, a very important topic of how agents, brokers fit in with the new small business marketplaces. That sounds like a good topic for some further outreach activities and coalition building. Question over here.
Hi, I'm Christine Monahan with the Georgetown Health Policy Institute Center on Health Insurance Reforms. And before I get to my question, I just want to quickly note that I and my colleagues, Jack Cobley, Sabrina Corlett, and Laura Summer, put out a paper with the Robert Wood Johnson Foundation last Thursday on Medicare Part D and the lessons learned for health insurance exchanges. So I'd encourage people to check that out. My question is on the timeline that Mandy put up. And specifically, I saw that the in-person assistance training is expected to start in July, with Navigator Awards coming out in August. And so are you expecting that to primarily start with agents and brokers, or will entities that apply to be navigators kind of, just get started in July so they can get ready immediately when the awards are made? Right. And just if anything you can share on the navigator training.
That does seem like a tight time frame.
What do you mean? So great question. So so we know that the navigators are a federal grant program and will be awarded in August, and they'll start training immediately and to be up and running for October 1st. But there are other flavors of folks that can be in-person assistants, agents and brokers being one of them. And so, given that this is their bread and butter and not quite as extensive training needed, obviously, and so we're able to start some of that as soon as we possibly can. But then there's also a category of in-person assisters called certified application counselors. Those are folks that are not federally funded, but are folks that are likely already doing enrollment type work, either through Medicaid or other, who might want to learn about the marketplace and get to a place where they can also assist to help people walk through this single streamlined application and the whole process. So we are hoping to get that ready to start people through that process. So, folks in hospitals who already have folks that are doing enrollment and likely want to expand their knowledge base. We also know that the community health centers, we put out some funding for every community health center across the country. That will be awarded in July. They'll have an opportunity to start some of that training ahead of time.
Question over here.
Hi, I'm Dr. Peter Rick-Meneman, Senior Policy Fellow with the American Nurses Association, and I'm the health economist for the association. 30 years ago, I was the Chief of Physician Reimbursement Research at HCFA, so I'd like to draw a lesson from Part B rather than D. In 2011, CMS says more than 100,000 advanced practice registered nurses billing under their own national practitioner identifiers provided $2.4 billion of approved charges to 10.4 million Medicare fee-for-service bennies. It's 30% of the fee-for-service population. There are lots of advanced practice nurses who can provide one or more essential health benefits, but what we know about the current private health insurance market is that only half of the private health insurance plans in the country credential advanced practice nurses. We are hopeful that in the network adequacy standards that there will be a level playing field, and anybody who can provide an essential health benefit and is licensed in the state to do so will be eligible to be a participant in the plan, to become a member of the networks. But it seems that SOCIO is sort of laid back in terms of how that's going to work. We're not asking that all nurses be mandated to be included in the benefit packages, but we're hoping it's going to be a lot more open, and that because of everyone's prediction of primary care physician shortages, that we don't ignore an important source of potential service to improve access, which is what the whole idea was in the first place.
Gary?
I think all I can say at this point is that we definitely recognize and appreciate that if we're going to bend the cost curve, the biggest part of the cost curve is the cost of providing care, and one way to do that is to enable care to be given, as you described, by people other than MDs, and so we are certainly aware of that as an important issue, and we'll continue to work toward making sure that affordable care is available.
This actually does bring up a broader issue, and I know the plans aren't out yet, and you're not going to have the specific premium details and so forth till September. One of the things that was pretty remarkable to me about the Part D experience was how quickly people moved in this kind of competitive structure where they had a sort of a contribution the government made on their behalf, but they got to choose. How quickly they moved to benefit plans that were not at all sort of the standard benefit defined in the legislation and the standard structure with a deductible and 25% coinsurance and catastrophic protection on the back end, the famous donut hole in between. Right. People from day one gravitated to plans that were lower premiums overall, and that gave them kind of much stronger opportunity to get savings when they switched to less costly drugs that met their needs through the so-called tiered benefit designs. That's what was really popular in Part D and was, I think, a direct outgrowth of the way the benefit was set up and the policy decisions that we made to allow that kind of flexibility. Are you seeing anything notable that you feel comfortable in talking about now in terms of new approaches emerging in networks and new ways of delivering care more efficiently, or something that might be kind of equivalent to that shift in coverage that we saw with Part D?
Yeah, I mean, I definitely think we are seeing more of a movement toward the accountable care organizations and partnerships between providers and payers, so that everybody has some skin in the game. And obviously there's a lot of talk about changes in the health delivery system overall and away from fee-for-service and more outcome-based, and those are all efforts that the Affordable Care Act also addresses and the administration is promoting. I think we are seeing, in terms of what is coming in, some interesting new. There are narrow network plans. There are other approaches that issuers are taking to try to keep costs down. And I think from the consumer standpoint, one of the things that will be very different and very helpful to consumers is that they will be able to compare across a range, from the bronze to the silver to the gold, in terms of what difference that makes for them with respect to what their premium is going to be versus what their out-of-pocket cost is likely to be, and make some choices in terms of what is their expected medical cost and what really makes the most sense for them. But they'll be able to do that in a way that really is sort of apples to apples, because the essential benefits are there, and so they really are comparing on network, price, copay, deductible, et cetera, as opposed to trying to figure out is this going to be covered, or is it not going to be covered?
Can I comment on this?
Yeah, please.
I'd left government and formed a business, and it has just under 50 employees. And in September a year ago, we got a 22% increase in our premium. And I and my colleagues concluded that that was not going to work for us. And we happen to live in a state where there's a small business exchange, Utah, where we formed the exchange before all of this started. And so we had a meeting, and I proposed that we have a different relationship. In the past, we'd paid 80% of the premium. And I suggested we'd pay 80%, but this year we'd add 6% to that, and that everyone could take their check and essentially go to the small business exchange and make a decision on what plan they wanted. And I was, of course, fascinated to watch how this would all play out. To a person, every one of them adopted essentially the same strategy without a lot of coordination. They all took their check for 80% plus 6%, went to the small business exchange, and looked for a plan where they could pay 100% of the premium. And they all found them. And here's why. They did two things. They took more risk themselves, and by having a higher deductible, and they started looking for a narrower network that had things like nurses and so forth that could provide the basic coverage. They made very well thought out decisions about their own care. And I believe it's just an N of one. I don't represent it to be anything other than that. Except from my standpoint, I am the employer, and I have employees who are quite happy because they chose a plan themselves. I think it had the effect of making them more conscious because they were making decisions on their own benefit design. And I do think it's the reason that we'll begin to see lots of uncoordinated choices being made that will begin to drive a market toward this, and that government, whether it's Republican or Democrat, is going to have to be responsive to that, because that's essentially what people are asking for.
It'll be interesting to see how that emerges. That was, again, a very big deal with Part D, that kind of change, and it sounds like you're seeing it in some of the small business exchanges now, where this key feature of people having a set amount of money that they can use towards coverage really changes.
Which was, by the way, the key to Part D.
Yeah, that's right. I think we have time for maybe one more. Back in the back.
Hi, my name is Aline Singer with the Heritage Foundation, and I just have a question for Dr. Cohen. In regards to consumer assistance, is there a fundamental difference between the in-person assisters and the Navigator program, or is it just a funding difference?
So the Navigator is a federal grant program, so it's a funding difference.
Actually, we have time for one more question. I think that one was quick. Go ahead.
Very efficient.
Thank you.
Hi, I'm Charles Trotzo. I'm a local economist, willing to expose his ignorance. We're talking a lot about making the consumer well-informed and better able to maybe evaluate his risks. And we know nobody really knows how to evaluate their risks very well. But on the other hand, there's the other side, and that's the supply side of the insurance. What's to assure that the insurance industry is going to be competitive and that competition will be maintained? Or will it be up to the local state insurance regulators to do that, which I don't think has the greatest experience behind us?
So, as I mentioned before, we are grappling with a market that in many places today is very highly concentrated, with the typical profile being, one sort of dominant carrier and then maybe a couple more with some significant market share, and then a whole bunch with very tiny market share. And I think this moment, represents and in the past they have manage their business in a way that was essentially geared in the individual market, certainly, to managing risk. So they avoided insuring sick people, either because they just flat out wouldn't give you a policy if you had an adverse health condition, or the price was so high that it was unaffordable. And that's going to change. And we're creating a new market where there's an opportunity now to sign up millions of people who, many of whom will get help in paying for their coverage. And I think that what we're seeing is that this is opening up a possibility, because these are people who don't have an allegiance to an existing carrier, don't have, haven't already made a decision to be signed up with, one particular company, but it really has opened up, the market. And so I think, what we're seeing in terms of the applications that have come in, and what we're hoping to see going forward is this, new opportunity to market to a whole new group of people who will be getting assistance in paying the premium, will encourage more competition in the marketplace than what we've seen, typically.
I think we're about out of time. I'd just like to ask all of you down the row if there are any final thoughts before we wrap up today. Mike?
I have no more thoughts.
I'm thought out too.
Okay, yeah. We're all thought out, but clearly this is, as we've said, one piece in what will be a longer and complex story still to be written. Maybe following up on Gary's comment, we could take you up on another event later on this year. We can see how Mike's small business is doing in terms of cost and coverage heading into 2014, and obviously lots more to talk about as implementation continues. I'd like to thank Mandy and Gary for taking time out of what I know are very busy schedules right now to spend so much time going into these issues this morning. Mike Levitt for providing a tremendous perspective, sort of just like old times with me. And of course, thank all of you for joining us today. Please stay tuned. We'll have much more to say about these and other issues related to healthcare reform from here at Brookings. Take care and have a great day.